to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I'm your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts from around the globe and around all aspects of drugs and addiction. Today's episode is sponsored by ISAC, the International Academy on the Science and Impact of Cannabis. Visit their website at isac1.org, IASIC1.org, to follow the science on marijuana. Friends, fentanyl is plaguing America. There is no safe drug supply unless it comes from a legal pharmacy. If you are around anyone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. Hello again, High Truth listeners. Get ready for some science, research, and innovations. I'm your host, Dr. Ronit Lev. What is the world's most renowned organization for science, research, and innovations? The National Institute of Health, the NIH. The NIH is the United States Medical Research Agency. NIH is made out of 27 different institutions and centers, each with its own research agenda. A center for cancer, for heart, lung, and blood, a center for allergies and infectious diseases, Anthony Fauci's place, and there's a center for addiction, the National Institute of Drug Abuse, NIDA. NIDA can trace its history to 1935 with a small addiction research center in Kentucky to now a $1.8 billion agency with 389 full-time employees and over 2,000 research investigators. They invest in research for basic neuroscience, epidemiology, risk and preventive factors, prevention, treatment, and implementation. NIDA provides the gold standard to the world on issues of substance use disorder. And with that, let's hear our question of the day. Hey, we don't have a question of the day. That's because we are welcoming in 2023 and have multiple questions of the day from a few people to an international medical rock star. Dr. Nora Volkow is the longest residing director of the National Institute on Drug Abuse, NIDA, and has been there since 2003. She is the world's go-to person when it comes to the issue of drugs. She was named top 100 people who shape our world and has been instrumental in demonstrating that drug addiction is a brain disorder. To learn more about Dr. Nora Volkow and NIDA, please visit the High Truth show notes. Dr. Nora Volkow, welcome to High Truths.
Hello, how are you? Thanks for having me.
It's great. It's always an honor, inspiring to get to talk to you, so I'm excited. You know, I thought we'd do something different. People have so many questions to you about drugs and addiction. My first question to you is, I want to get, I've known you now for several years, but can you share with us a little bit about you, the woman behind NIDA for almost 20 years?
Yes, I was born in Mexico. I went to medical school there, and I've always wanted to understand how the human brain works. And I was particularly intrigued about how drugs can so profoundly change behavior of people and drive their motivation in ways that make no sense to people that are not taking them and become addicted to them. But I was also very frustrated as a physician in training that we weren't taking attention of these people, that we neglected, that we stigmatized them. And so if you put these two things together, my interest of understanding how the human brain works and my frustration as a physician on how we were treating people with substance use disorders, then you can understand why I chose psychiatry as my specialty. And so I left Mexico when I finished medical school, and then I went to New York University to start my training in psychiatry. But what led me to New York University was the fact that it was the first academic center involved with the use of a newly developed brain imaging technology, positron emission tomography, the first the first technology that allows us to look inside the human brain in a three-dimensional way and at a higher spatial resolution than what we had observed in the past with, for example, electrophysiology, which only records in the surface area. So that's why I ended up in New York University, because they were doing studies with positron emission tomography to investigate what was wrong in the brain of people suffering from schizophrenia. So I ended up in NYU for that. And of course, immediately as I started my residency in psychiatry, and concomitant with that, I started to work on research projects to investigate whether there were changes in the brain, metabolism, which is a good marker of brain activity, in people suffering from schizophrenia. And that's how my whole career on brain imaging started. And so I went from studying brain changes in schizophrenia to focusing the use of this technology for understanding how drugs affect the human brain in people that are not addicted, but also obviously then jumping into how drugs affect the brain in people that are addicted, and trying to understand how those changes actually account, how do they help us explain the behavioral modifications on people struggling with addiction. And then someone offered me the position of NIDA director, and I didn't want to do it because I love science. But they convinced me, and they said, Nora, what you can do as director of NIDA can be so much broad-reaching than what you can do as a scientist. And so I agreed to do it under the condition that I could keep on doing research. And that was 19 years ago. And I basically never regretted the choice. It's been a really incredible opportunity to be able to work alongside a really extraordinary group of people at NIDA, but where our mission is to provide resources to these incredibly bright and creative people in order to help us advance the knowledge of substance use disorders, and also to help us advance that knowledge into translational products, so that it's not just knowledge that stays in a journal, but it's actually knowledge that is directly applied for prevention or treatment, or importantly, hopefully, to guide policies. So that's a very short description of my whole life.
And you've made such an impact, and you continue to do so. And what's remarkable is that you've survived, this charged political position through many different government administrations, which is, I think, a testament to your wisdom and the trust that you have with the American people.
Yeah, no, but one of the aspects that has helped me enormously is that the position of director of the National Institute on Drug Abuse is not a political position, which is not the case, for example, for the person that directs the NIH, or actually there is a director position at the NIH, that of the Cancer Institute, which is also political. But when you are not a political appointee, you have much more flexibility and freedom. And the other philosophy that I have taken from day one has always been, look, we are a science organization. We are based our value in terms of obtaining evidence and data. And the moment that you ask me to shade that data, to change the coloring of that data on the basis of political pressure, you lose any value that I can give you as a scientific agency. So my argument has always been, and my strategy is, here is the data. You can ignore it, or you can use it to actually do better choices. But I don't ever give opinions of me, Nora. I basically present the data and let the data do the opinioning. It's not me. So I remove that personalized component. And I think it's a strategy that we should all use in general in science, right? Because if we are, the science speaks for itself. I don't need to say anything, right? And it's like when people ask me, well, should we legalize more drugs? And I said, well, just look at the cost to lives and morbidity that we have from legal drugs, and you make the math and you decide.
Right. But I like taking your science and your data, and for me as somebody who lives in a community, want to make that into action, but based on your science. But really, I really attribute to you. Wherever I go, people who have met you or dealt with NIDA always say the same thing, that all the staff is very caring, passionate, and very pleasant to deal with. So really a testament to you, because you said that you mentioned your history, but what you didn't maybe even know about yourself is that you're a great organizer of people to run such an agency that has such respect.
And I want to say it. I mean, it's absolutely completely true. I'm not saying it for any diplomatic reasons or not. One of the most reinforcing components of my job is to work with my staff at NIDA. They are pretty extraordinary. And again, I do not give them for granted at all. They are just fantastic. And I love their mission, their passion, their creativity. So I'm not surprised other people also see it in them. I'm very lucky to have such a fantastic group.
Yes, it shows. So a question about the name, NIDA, National Institute on Drug Abuse. There's controversy now with the word abuse and the stigma of it. And so is there a movement now to change the name of NIDA?
Yes, indeed. And it's not the first one I've done. I mean, actually, when I became director very early on into my tenure, I tried to change the name because I hate abuse. It's physical, sexual abuse. I mean, we have these associations with condition. And after something like 10 months of intense working, they decided, no, we're not going to do it. But now it looks like it will happen. And I'm expecting it will happen at the beginning of the next year. I hope so. The new name will be the National Institutes on Drugs and Addiction. So it will keep its NIDA, but we will get rid of the term abuse.
So get rid of the term abuse. And I know there's a lot of work now about stigmatizing language. I've noticed people who are in treatment and people in harm reduction are very sensitive to the language. But people who are in recovery don't mind saying abuse and don't mind calling themselves addicts. What's your perspective on that?
Yeah, and there is differences on the way that people look at language, and I think that we have to respect them, and which makes it also very difficult to come with an agreement about what are the optimal terms. And researchers have been looking at that, and we've done a lot of surveys with patient groups and their families, as well as other social groups, with respect which terms are offensive and demeaning to people. And clearly the one of abuse is a term that is has very negative connotations. And it's also that in terms of the term, for example, addiction, overall the sense, and this is consistently endorsed by a lot of people, is the term you are an addict is of course very demeaning. But stating a person suffering from addiction is not. So you are modifying the language between transforming the identity of the person to the condition. You are an addict, as opposed to actually identifying someone that has a condition, just like it's a person suffering from cancer or a person suffering from mental illness. That is the proper way that people feel about. But within this dialogue, of course, the term addiction itself is not actually seen as pejorative. And on the other hand, it is more precise in certain instances and narratives than when we use the term that is now the new diagnostic criteria of substance use disorders. Why? Because individuals not all individuals with suffering from a substance use disorders have an addiction. I mean, if you look at the descriptions, someone with a mild substance use disorder really does not fit the category of suffering from an addiction. They are at the early stages, sort of like the term that we've started to coin, which is the pre-addiction stage, a stage where you are at greater risk. And it's important to identify it because it highlights the opportunity to do an intervention. And this term of pre-addiction was very much sort of inspired by the term of pre-diabetes that led then to the ability to identify people that are higher risk of diabetes. And concomitant with that, there is sort of categories that allow for reimbursement of interventions for individuals suffering from pre-diabetes. And so we want to be able to create such a category that will then allow for clinicians and healthcare providers to be able to be reimbursed, and therefore for them to be incentivized to screen and intervene with individuals that are suffering from pre-addiction. But so coming back to the whole issue of term, that's why we are still using the term addiction, and why actually the National Institutes on Drugs and Addiction was selected.
Interesting. So mild SUD equals pre-addiction.
That's we're proposing that, that it is mild SUD. And this became important, for example, when you have, we are living this overdose crisis where really unprecedented number of people are unfortunately dying from overdoses, predominantly driven by fentanyl, but in many instances, the consumption of the fentanyl is hidden in the drug that the person thinks they are taking, cocaine and methamphetamine, which is laced with fentanyl, and they die. And and in the case of people with opioid use disorder, for example, they are at the highest risk, but the will give, and we have buprenorphine and methadone, which work very well for preventing overdoses and helping achieve recovery if the person takes them. But you are not going to give someone buprenorphine or methadone if they are basically in the early stages of a substance use disorder, in the mild cases, which can be suffering from basically tolerance and withdrawal. And that is going to happen to any one of us if they give us an opioid for therapeutic. It's going to happen, and it happens relatively fast. So does that mean I'm going to put you on methadone? No. But we haven't tackled that issue of what is actually the best strategy to do an intervention on this early stage. And that's where the whole concept of pre-addiction also could be very valuable, because it will incentivize not just to get reimbursement from healthcare, but hopefully researchers to try to identify, first of all, the importance of screening, but importantly, what intervention should we be doing right now where the illicit drug market is so dangerous because it's frequently contaminated with fentanyl, so we can protect those people and protect them and prevent them from overdosing. It was not like that in the past, but it is now. And so this is another aspect about why we're so interested right now on pushing the concept of pre-addiction, which we basically are equating, as you asked the question, of just basically mild substance use disorder.
That's great. That's important. I think I saw your article that you published about pre-addiction, and went out, and I will have a podcast just on talking about that, because that's so important, as you mentioned. I have different people who have questions for you, High Truth fans and experts. And so if you don't mind, Julie Shamish lost her son Tyler to fentanyl poisoning, just as you described, and since then she established a Drug Awareness Foundation. She wants to know what your take is, and you kind of talked about that, about the terrible increased toll of mortality data. I remember one time when you spoke at the RX Summit years ago, before fentanyl was making its logarithmic climb. It was just a blink. You said we cannot afford to allow fentanyl to be a trend. You predicted the disaster, really, that we're living through now. But so now that you're looking at the current data, the latest data, what's your mind telling you, like you say?
Well, I mean, my brain is telling me. My brain is telling me. I mean, I sort of, and the story that you're telling is just so very tragic. But what it is telling me in my brain is always sort of say, this is why this is so incredibly urgent. And it's also telling me it's not a problem that's going to go out by itself, and which basically highlights the importance of coordinating our actions and using the evidence to guide them. Coordinating an evidence-based and to ensure that we have the resources to sustain those actions. And why do I say that this is not going to go out by itself? I say it because, to start with, the profits that the dealers are making with fentanyl are enormous. And it's a very, very powerful reinforcer. And they also have the incentives on actually continue to work with chemistry and innovation to develop increasingly more powerful drugs so that they can make more and more money. And they are going to be very aggressive in the way that these drugs are distributed, as we're already seeing across all of the United States. In a period of few years, it went from isolated areas in the United States where you had fentanyl to now covering the whole United States in remote areas, in Alaska, in rural areas, in multiple places, in areas where typically you had not seen fentanyl. For example, the whole West Coast was predominantly methamphetamine. And now you know that's not, that we cannot basically say the West Coast is safe from fentanyl. So this is the tremendous amount of profits that can be made, and that the facility with which it's distributed and the ability to use technologies like the web in order to be able to advertise and sell these products are very, very powerful. And unless we are asked, basically, as I say, proactive in integrating, providing the evidence-based treatments and prevention, and providing the resources to deploy them, they are going to continue to win the battle to a certain extent, as we're seeing, very unfortunately, by the tragic loss of so many lives. You always look at things, I mean, this is a horrific tragedy, but when you look at the horrific tragedies, in a way, it also brings in us that urgency to actually, on the one hand, work together. One would hope, I tend to be an optimist, but also in this case, the recognition that we need to pay attention to this issue. And as you know, in addiction, ultimately, it's a disease that is neglected and is neglected and stigmatized. And so realizing that this attitude that we have had as a society is one of the reasons why we find ourselves here. And why do I say that? I say that because in the healthcare system, in medical school, nurses, dentists, many of the medical professions are not that trained on addressing substance use disorders. And until very recently, there were no costs really to reimburse at the same level. Substance use disorder, actually, we are still not reimbursing at the level that it deserves as it compares to other medical conditions. So this discrimination against substance use disorders have weakened our system, our structural systems, to provide the prevention and treatment that would have obviated very much, I think, the current overdose crisis. It would have made us alert too about much earlier than when it happened, that overdose deaths were happening, that people suffering from pain that were given opioids were becoming addicted to them. Clinicians, not having been trained, were not able to recognize it. And if they recognize it, did not know what to do. So this is where I see that ultimately, this is the things that the story you are telling of a mother who loses a child and loses a child out of, an occasional drug use, or even if it was a frequent drug use, because that drug was contaminated with fentanyl, is going to continue to happen unless we become very, very strategic and committed, all of us together, to stop it. But I do believe it can be stopped very much.
We don't have enough. Like if I admit a patient to the hospital with an infection because of their substance use disorder, they'll get an infectious disease consult, hospital's consult, ICU consult, cardiology if it's their heart, but they won't have someone to treat the underlying cause of all that. I'm jealous of the palliative care services that are available throughout the United States for a small population, and we really need an addiction service at hospitals throughout America that would fill up very quickly. But you mentioned Julie. Julie became my partner in passing a law in California that will require fentanyl to be included in all drug screens whenever it's ordered in the hospital. I think I talked to you about that years ago. You know, we wanted to bring that awareness. So we now in California, thanks to Julie, will have the first law in the United States that whenever a drug screen is ordered, it will include fentanyl.
Congratulations, and I'm very glad you passed that law, and I think it will serve as an example to other states.
Yeah, and if you talk to anybody who says, oh, I'm a rural hospital, I can't do it, send them to me, I'll teach them how.
Yeah, no, and bravo. I think bravo to you and Julie. This is quite an accomplishment, because one of the problems that we're facing is because we don't have data on ultimately what is driving the overdoses. We basically are operating many times in the dark as it relates to how to properly treat that person on the one hand, but we're also operating in the dark as it relates of what is the magnitude of the problem of fentanyl. And without that information, there's no reason why we should not be getting that information. And so I heard it from many emergency department physicians who says, you know, we just basically give naloxone, but we really do not have the structure to be able to test whether it was from fentanyl or not.
Yeah. So I would tell all of them that, yes, you have the structure, you just need to implement it. It's there. You just haven't talked to your lab and made those connections. But again, I'm happy to help. I have a toolkit available to teach any hospital in America how to get that done.
When I ask that question, though, they say to me, it's very expensive. So how?
75 cents. 75 cents. Arc reagent costs 75 cents. Not expensive.
No, I agree. 75 cents. That's sort of actually I'm glad to hear, because that was one of the answers that I got consistently. Oh, it's very expensive to get it done, and we don't have the capabilities.
Now, clinic, it is expensive. There is no FDA approved, and I've talked to the FDA. There's no FDA approved multi-drug fentanyl testing if you're in a clinic setting. But every hospital in America, big or small, rural, has a chemical analyzers that tests for CBC and chemistry panels. You add that 75-cent reagent of fentanyl, and every hospital in America, there's no excuse that we're not all doing it.
Okay, I'm going to send them to you, unless you want to give me the link of the information, and then I'm not.
Yeah, after this call, I will send you the link to our toolkit, because it's available nationwide, anywhere. So happy to dispel that.
I think it's great. Great. When you told me about it, and I think it was like 1 year ago, more, and I said, this sounds wonderful. So I'm glad that you did it.
Yeah, and it was a Republican senator who carried it through a California Congress, and it had really no opposition, very little. So that was good. Dr. Nathan Painter is a professor of pharmacy at UCSD, co-chair of the Healthcare Task Force. And his question to you is, what's the one thing that we can spread in our communities to prevent SUDs?
Well, I think that it's not per se one of the areas of research that we have worked on, but I think that the data out there, the evidence is very, very strong that the use of condoms is probably one of the most effective interventions in order to prevent sexually transmitted diseases. And so, and one of the issues that we have seen, for example, is as the antiretroviral therapies became clear that if you treat someone with antiretroviral therapy for HIV, they are not going to be infected. Their likelihood of infecting someone else is very, very minimal. And so that led, of course, to a much greater freedom on sexual practices and the lack of reliance, among other things, on condom. And that in parallel, that change in behaviors was associated in a rise in other sexually transmitted diseases like syphilis.
But I had a conversation with Bob DuPont, drugs NIDA director, right before you, and he said that the analogy of sex and drugs is not the same, because there's a biological drive to have sex. There's not a biological drive to use drugs. So if we prevent youth from starting in the first place, we won't get to zero, but that would be the most upstream approach.
But sexually transmitted diseases are actually occurring whether in people that use drugs or not. When under the effects of a drug intoxication, then people tend to engage in riskier behavioral practices. And we know, for example, that is the case with methamphetamine. And in fact, among men that have sex with men, we've always recognized that because of studies that have evaluated and gone into the field to get information that many individuals, when they want to engage in sexual practices, they do consume methamphetamine in that context, and they feel freer and more daring. But that comes at a price because they are going to be doing behaviors that are much riskier. So in that context of drug taking increases risk. But irrespective of whether the person is taking drugs or not, one intervention that actually could prevent sexually transmitted diseases is the use of condoms. So independent of anything else, I'm just sort of bringing it up. Apart from the fact that this is not research that Austin Institute has worked on, and is more on areas of infectious disease prevention in general.
So what is the condom for drugs? Is that the Narcan, naloxone?
Well, no. The condom use basically is something that prevents an infection, right? So a condom will protect a person from getting HIV or syphilis. But a naloxone, if I take naloxone and then I take a drug, first of all, if a person is a drug user and they take naloxone, it will trigger a withdrawal. And so naloxone is a medication that is very useful to reverting an overdose, but not to take it before you take a drug, because then you're going to generate a very aversive physiological and mental state of the individual that, if anything, is going to lead them to want to take more and more drugs. So that's why the metaphor does not work.
Okay. So I think you've mentioned, and maybe this is just not an area that NIDA is doing with this, is primary prevention, preventing very upstream approach. I think I've heard you talk about it when you talk about ACE and trauma and family and things that we can control. Some things we can control, some things we can't control, like your genetics, and some things we can't control, kind of like the risk factors for cardiac disease. But if we did that upstream approach, and again, I don't know if that's an area that as much that NIDA is looking into.
No, and thanks for asking that question. In fact, it's one of our top initiatives and areas of interest. I mean, all along we've basically been speaking, and characterizing addiction as a disease of the brain. And now our dialogue is basically saying, yes, it's a chronic disease of the brain, but with very strong social components to it. And so we emphasize how crucial those socially adverse experiences have in the basically increasing the risk of people taking drugs, but also increasing the risk that if they take the drugs, they become addicted, and also increasing the risk that if they are already addicted, they're much less likely to respond properly to treatment or to achieve recovery. So throughout the cascade from early initiation to later, the social determinants of health play extremely important roles. And as you mentioned before, because it's to me also the way that I view it, yes, our genetics are important. Some of us have higher risk for vulnerability for addiction, but how do you change them? On the other hand, you can modify or buffer environmentally adverse exposures by doing prevention interventions. And so within this whole concept, we've been funding for many, many years prevention research, and what we're right now doing is to try to understand at the neurobiological level, how do those socially adverse experiences or environments that researchers have recognized increase your risk, why is it that they do that? What do they do to our brain? And this is important because if you can identify the consequences that these adverse childhood experiences have in the development of your brain, then you can have a biomarker that you can use to see and evaluate someone and then apply an intervention and monitor whether you can revert those changes. And this is indeed one of the reasons why we launched the very large study of the ABCD, adolescent brain development of cognition, which is a prospective study that investigates exactly that, how the brain changes from age 9, 10, and 11 into young adulthood, and how those changes in brain development, how are they affected by your genes, by your environmental exposures, such as family income, adverse neighborhoods, exposure to stressors, and so to build up the knowledge base, and it's paying off. I mean, we're starting to identify now with much greater detail the adverse effects that these stressful social conditions have in the development of the brain. I mean, it seems to shorten the developmental period, which of course puts these children at a disadvantage, because the brain has on purpose physiologically a long developmental period in order to maximize its complex interactions, be optimal for responding to a very complex environment. So if you shorten that period, you are limiting, constraining that ability of the brain to maximize the environment in which it finds itself. So this is, again, why we are very much, so when you're asking me, are we interested? And I said, absolutely. And last year, we launched an equivalent to the ABCD study, but that instead of starting at age 9, 10, starts in infancy. Because obviously that period is also very important.
Right. So actually in San Diego, fentanyl was declared, a state of emergency, and our local leaders are now going to look into science, evidence-based education in schools, which we haven't had for many years, to start working on things at that level. So hopefully bring evidence-based and science into that methodology as well. So Marla Kincaid works for the Center of Community Research and facilitates the merged San Diego Meth Strike Force and our Prescription Drug Abuse Task Force. So she's asking, what are the innovations for addiction treatment? And I know that you probably have many things that are exciting to you that are on the horizon.
Oh, yeah, they are. And I just was making me smile because it's sort of, that's when I was saying before that I am optimistic that we can absolutely control it, because the science, where the science takes us, has advanced enormously. And one of the areas where it has advanced enormously is identifying targets that we can modify in order to be able, and when I speak about targets in this context, I'm basically thinking of molecular targets that then medications can go after. So say, for example, the treatments that we currently have for opioid use disorder, methadone, buprenorphine, naltrexone, they're quite effective, but there's only 3 different classes. So, and they all target the same receptor, the mu-opioid receptor. So now, for example, investigators are looking at other receptor systems, for example, the kappa opioid receptor system, which could also be beneficial, not just for opioid use disorder, but by a variety of other types of addiction. Similarly, the dopamine D3 receptor, if you can antagonize it in animal models, we know that you prevent relapse also from a wide variety of drug addictions. I just came from the meeting on the ACNP, which is one of the main pharmacological meetings, where the science of addiction is presented, as well as mental illness. And there were some really interesting data. For example, there's presentation of hormone-like molecules that act like hormone-like, that are synthesized, obviously in a chemistry lab, that can actually prevent cannabis use disorders, that can help cannabis use disorder. And it's very exciting because as of now, we have nothing pharmacologically to be able to help people suffering from cannabis use disorder, other than perhaps some of the synthetic cannabinoids that can be used for withdrawal, but not for addressing craving or that compulsion to take more. There was also some very, very interesting data that showed now molecular targets that can go, for example, to improve social behaviors. And this is extraordinary because one of the aspects that we've known along in the neuroscience of addiction is that social isolation actually exacerbates the severity of the drive to take drugs and interferes with the ability to regain recovery. But some of the drug effects actually directly interfere with those social networks in our brain. There's sort of big areas in our brain that are devoted to social behaviors, the motivation to want to be with people, that gets degraded in addiction. So the ability to create actually completely new targets that's why I say it's fascinating. Another area that I'm very, very excited about is the issue of neuromodulation. And again, there were several presentations on this, but it actually has advanced in such a way that there are multiple technologies that you can use. Some of them are most of them are non-invasive. You can use transcranial magnetic stimulation or direct electrical current stimulation or ultrasound on top of your head. And by understanding how the different areas of the brain connect with one another, you can target one region to affect the whole network. And that is being used for multiple substance use disorders. Similarly, peripheral nerve stimulation, like, for example, you have in your ear, you have a peripheral branch of the vagus nerve. And if you can actually stimulate it, you can improve withdrawal symptoms. Other researchers are actually for very severe cases where other treatments have not worked, are actually currently doing research for deep brain stimulation, where you place electrodes into the nucleus accumbens. And this is akin to what one of the treatments for Parkinson's disease is, which uses electrodes through the subthalamic nuclei and helps patients actually that actually have stronger responses than that they see with typical medications. So this is just an absolutely fascinating area of research. There's also a lot of interest. I'm actually optimistic on the basis of how we're advancing the whole methodology for development of immunotherapies. And immunotherapies involves both vaccines as well as monoclonal antibodies that are targeting the drug itself. And the idea is that the monoclonal antibodies, whether it is because you got a vaccine and you produce them, or you get them passively administered, that monoclonal antibody binds to the drug and interferes with it crossing the blood-brain barrier. So it just traps it in the bloodstream. And as a result of that, the person will not get high and the person will not overdose. So the challenges, and that's, again, where I say I am optimistic in as much as sort of the whole methodology is advancing with COVID has helped advance it enormously. So that now, for example, monoclonal antibodies can be delivered that have a longer lasting half-life than they used to have in the past. And that provides the possibility of getting a treatment. Vaccines are harder because you need to produce a lot of monoclonal antibodies to stop that drug from getting into the brain. And the vaccines, as of now, that we have are not producing sufficient titers of antibodies, but researchers are working on it. But on the other hand, we already know with the monoclonal antibodies, you can just load a very large amount. So that's very, very exciting. Another area, as you know, that has captured an enormous amount of interest is the potential of the use of psychedelic drugs for the treatment of substance use disorders. This is a very incipient area, and therefore we have to be cautious, and we have to be cautious in as much as it attracts a lot of attention. So it becomes sort of like, in a way, like a fairy tale. Okay, we have a magical drug that is going to cure substance use disorders. So whereas the data right now is still limited, but it does look extremely interesting. And it's opening up a completely new way of looking at medication. So normally you give medications, and while you're taking methadone or buprenorphine, it basically prevents you from overdosing, and it controls the withdrawal and the craving. But and that allows you to rebuild your life. And with time, as you rebuild your life, you can basically achieve recovery. But this type of medication is different because you take, say, for example, psilocybin, and you take the drug, and it binds to its receptor, which is the 5-HT2A. It's an agonist, it activates it. And as it binds to it, which can last 2, 3, 4 hours, you actually some sort of have this dissociative experience of meaning and senses that you don't normally experience. And then the drug leaves your brain. But if you follow these people, the effects are long lasting. So there was this acute effect of dissociation that lasts as long as the drug is binding to the receptor. And then there are long lasting effects on decreases in anxiety and on depression. And for in the studies that have been done with alcohol or with smoking, reduction in the desire to take these drugs. So there is a lot of interest right now on the potential of psychedelics, but I think it is where basically need more research in order to understand how to use it properly and who will respond, and to minimize potential side effects. Because in some people, the use of psychedelic therapeutics has resulted in increases in suicidal ideation. So we need to understand that to basically maximize any potential benefit that it may have, and do so in a responsible way.
But the problem I see is that NIDA says psychedelics may be, helpful in substance use disorder. And I understand what you're saying, that this is research, we need to do it, we still have to go through the regular process, FDA approval and everything. But what society hears is psychedelics are helpful for substance use disorder, so let's legalize them in California and Oregon, and creating more harm than good. So I'm wondering if you can, like, each time you say that, put the caveat. That
I always do.
Because what's happening is now you just go to Amazon and you just buy the psychedelics and all sorts of things, and increasing my business in the emergency department, because they take a little bit of truth and expand that. Okay, now all these psychedelics are good for everything, and they're being sold with this, that it's good for all these disease process, without the science. They take the one statement that, there's hope in research, and they're not going to wait for that. They're already marketing it and commercializing it.
Absolutely. No, I know that. And it's very frustrating. And is the same story as we have heard from cannabis, medical cannabis. But it's the issue when you have this invested interest of actually creating a profit from these products, that you start to get these non-evidence-based practices. And it's very, very harming. It's very harming both at the level of the individual, that can actually have very negative consequences. Again, and I sort of, when I do this presentation, I try to pick up the latest paper that gets with respect to show the increase in suicidal behaviors. And sometimes, unfortunately, it's suicide. To just sort of highlight why this whole area of research is absolutely not ready for clinical practice. It's not ready for clinical practice.
Thank you for saying that.
As we say this, but as much as we say that, and I will repeat it, the people that are interested on basically making a profit will basically just ignore it. And people that are very desperate, like with fairy tales, there is something in our brain that we want to believe of these magical, miraculous cures, and we become much more vulnerable if we are suffering from a condition. And I understand that, because you want so much to have something, and that whole notion of hope, how important it is. But the problem here is not the notion of the hope. I mean, the data is really not solid to actually be justified to generating the hope right now. The hope may come into the future. And again, as I say, but it does require that we understand it much, much better. I mean, the evidence is extremely preliminary with respect to substance use disorders, is stronger for the treatment of depression. Still, it's early on, but that is the area that's most advanced, and to a certain extent, post-traumatic stress disorder with MDMA. But research, I mean, this is why we do research.
Right. It reminds me of like the total public health picture. The vaping products are a good example of that. They say, oh, it helps people stop smoking. And I saw one of the studies that was shared with me from the CDC tobacco office, that for every one person who maybe stopped smoking using vape, we've created 80 adolescent new users who never would have in the first place. And they had calculations that for every 100 years saved by vaping, we've cost 100 million years of lives by people starting vaping in the first place. So yeah, maybe it helps a few people, but the greater societal harm, I think, was not worth it.
But my perspective on this is actually is somewhat different. I think my perspective on this, we are always going to be finding interventions, therapeutic interventions that will have a benefit for a group of people, but if they are not properly regulated, can produce enormous amounts of harm. And I see electronic nicotine cigarettes the same way. The basically, on the one hand, the recognition that we need to regulate them so that they do not become available and accessible to people that are not finding or fighting already with a nicotine addiction, while also recognizing that in people with severe tobacco use disorder, these products can provide some benefits. So they are not antithetical. And we have, I mean, our brains are extraordinarily complex, that we have this social system. There's no reason why we cannot generate a system that allows us to use it. It's the same argument in terms of, for example, fentanyl. Yes, fentanyl is incredibly valuable for anesthesia. It allows you to bring down the utilization of anesthetic agents, and with basically minimal or no risks. You are in a sort of surgical suite. You have patients intubated or with an anesthesiologist monitoring their oxygenation.
I give fentanyl all the time in the emergency department.
Yeah. So there you see, but fentanyl, on the other hand, outside that world, produces a horrific overdose crisis. So I view it the same thing with respect to the nicotine electronic cigarettes. And one of the issues that we have been trying to work on is to develop, if you could get for example, let me give you an example about these issues, some of the low-hanging fruit. Why can we not just determine that electronic nicotine cigarettes have been actually available only through a prescription?
I was just going to say that. If following your theory, then it should be available through prescriptions for people who have a severe nicotine disorder, instead of having all these teenagers be vaping.
But that's exactly a policy that one could conceive. I mean, I just sort of throw it in my brain. I mean, there are nuances into some of these issues, because you also want it to be available to people that may not have insurance, or so how do you create systems that allow you to make it accessible and equitable to everybody that could benefit from it, and at the same time protect everyone? We've done it in the past, and it's going to continue happening, because it is not uncommon to have therapeutics that are useful for some people, but they also have very negative effects when they are used outside that clinical context.
That's great. James Rao is founder of Families Against Fentanyl. His son died of illicit fentanyl, directly traced to China trafficking. And he's advocating for illicit fentanyl to be declared a weapon of mass destruction. What is your opinion of this drastic measure to reduce supply? And I know you say you follow the science, not the politics, but maybe mention about the science of the supply side and having ways of preventing these drugs coming and preying on our population.
Yeah, no, and it's a very, very tragic story. And I understand. I mean, it's just devastating. You lose your son for a drug, for the profit of someone that's profiteering. I mean, it's just very enraging and angering. And so there is no ways around it. I mean, because obviously the data shows that one of the components that determines which drugs people take has to do in part to the access to those drugs. And in the case of fentanyl, the access to those drugs is just so very easy. The low hanging bar of getting fentanyl, well, even when you don't want it, just because it's so easy to manufacture. So I do, and then basically the data supports very strong interventions to minimize the availability of fentanyl as one of the strategies that is necessary. So apart from the whole notion, of course, we need to do prevention and treatment for substance use disorders, it is also important that we do everything we can to minimize access of these extraordinary dangerous drugs for people that do not know. I mean, they don't know the risk they are taking. And this is, again, affecting all segments of the populations, from teenagers, where we didn't see overdoses from fentanyl in the past, to older people that may be purchasing these or prescription pills through the web and end up with an illicitly manufactured pill that contains fentanyl, and then they overdose and die. So it can just diversify the demographics. So controlling that is one of the components that is necessary to basically just stop this overdose crisis.
So you support working on the supply part.
Absolutely.
Okay. And another question comes from Cindy Cipriano. She's a senior management counsel of the Office of U.S. Attorney. She's co-chair of our drug abuse task force, and she noticed that there's a division. We know that we have a division in America, but there's also a division between people who are working on the issue of drugs, from people working on primary prevention in schools and youth, and those people who are promoting harm reduction, and law enforcement and reducing the supply side. And sometimes it's, a competitive environment instead of together. So what can you say to unite the different groups? We're working with different really cohorts of addiction, but we all have the same goal of saving lives. What can you say? And I'm sure you do all the time, you bring your message, but how do we unite these communities who are working with different cohorts rather than have them feel like it's competitive?
I guess that the main message is how important it is for all of us to integrate our efforts. And I wouldn't say that there is one specific recipe that will work in order to bring people together from that very diverse perspectives or issues that they are addressing, because that will depend very much in the community. What we are doing as a research agency is to actually helping fund sort of examples of interventions that then can be developed and translated into other communities that show success exactly on that, on bringing the people that are involved with primary prevention, on bringing the healthcare system that is involved with the treatment and follow-up, in bringing the community that provides the support to achieve recovery. And that community also is the one that can solidify and strengthen opportunities for doing primary prevention. So we are generated sort of demonstration projects that can then lead other communities to see how did they do it, what were the active ingredients that are crucial to make it successful, but at the same time tailor it to the situation, to the local situation. That is, I think, a strategy that as we advance and others see, and again, that takes roots in the community itself, hopefully will start to take a stronger movement in our country. And I also hope that, just like we've, one of the priorities that sort of from the perspective of NIDA has been to show that through the healthcare system, we have a very powerful first line in defense for therapeutics. I mean, a system that can be used and should be used to deploying for screening and therapeutics of substance use disorders, and building the models that allow us to do that, and or justifying also through the findings the importance of reimbursement to sustain these capabilities. And so we would hope that a similar process can be created so that we can build a system, just like the healthcare system, to provide the prevention, which currently we don't have. Prevention, as you say, is done isolated by healthcare systems, by communities, but we don't have a process by which this is reimbursed and systematically in any way. So as a result of that, it's weakened and very dispersed, and basically with very few connections. Trying to build models that connect, and also trying to build the evidence that hopefully will provide the resources to sustain that structure that is necessary for prevention.
What I do is I explain to people is I have all these groups. I have them sit at one table, one Zoom conference, and we meet every month. And even though people have different perspectives, I explain that you're working with different population cohorts. So there's a population of cohort of people who've never used drugs. And the prevention message to them is, good job. This is a social norm, and continue to protect your brain. We want you to protect your brain at least to age 25. So that's one message. The second cohort is people who are experimenting with drugs, like you say, maybe pre-addiction or just even experimenting. And the message there is the dangers of fentanyl and having naloxone and the contamination of the drug supply with fentanyl. And then there's a different cohort of people who have a substance use disorder, and they deserve treatment with compassion. And if they can't do treatment, then at least harm reduction. So I think by separating, because people mix up the prevention message, when we see posters like, use needles. Well, that doesn't apply to the kid who doesn't use drugs, and they don't listen there, right? Just like somebody who's using drugs and you say, just stop. That's not going to make sense to them either. So I've tried to separate to different cohorts, different prevention messages. Does that make sense?
Absolutely, it makes a lot of sense. And I would just note a fourth group, which would be people that are taking drugs occasionally, not for experimenting with drugs, but because they actually are taking them for their psychotherapeutic beneficial effects, such as helping them sleep or helping them pay attention or helping them deal with pain when they cannot get the medication from their provider. So that's the one that we were discussing before, that they may end up by purchasing one of these illicitly manufactured prescription pills. Mm-hmm. So that message is also important, that it is dangerous currently to purchase prescription drugs from the illicit market, because even though they may be much cheaper, they are advertised. Of course, they are much cheaper than one that is properly manufactured. The risks are very, very high.
Thank you. Thank you for always teaching me. My listeners know that I'm very jealous of infectious diseases. 5 cases of Shigella, and we open up hotel rooms for them. 2 cases of wound botulism, and the county sends a public health alert. And not to mention COVID, flu, RSV, always in the news. Can NIDA use the same type of infectious disease models? And I asked you before also if you too are jealous, like me, of an infectious disease. And I talked to Dr. Tom Frieden, who previous CDC director, and he has this like healthcare pyramid of, on the bottom, what society can do in preventing a problem, like removing trans fats from the food supply, or mosquitoes for eradicate malaria. And then there would be, different levels. At the top of the pyramid would be like the individual things that people could do to treat their high blood pressure, diabetes. Do we have the same model? I've tried to make a slide, like making similarities with that and for drugs. Maybe that's a paper I should work on, but what do you
You should, absolutely. I think, and I was also saying yes, because I use exactly how effective we have been in, for example, addressing very, very rapidly the need for vaccines on the COVID pandemic and antivirals. We put enormous amounts of resources and basically the structure and the training. And I said, look, we are basically losing as many people or more from overdoses than we are from COVID. And yet there's nothing in terms of the willingness to put the resources that are necessary, a fragment of the resources that are necessary, which I think reflects two things. One of them, of course, the whole stigmatization that we have of substance use disorders, which is reflected by the very limited attention that it gets with respect to the level of resources that are that we are deploying to it. That's one. But also, obviously, with the COVID pandemic, it was something new. And the same thing happened when we had Zika, and the same thing happened with Ebola. There is something that is new. It generates a very intense reaction, as it should, as opposed to things that goes much slower. And so even with the overdose crisis, it was been much slower than with the COVID pandemic. And that determines to one of the how much effort and attention it gets. But irrespective of that, I mean, whichever way that you look at it, the level of focus that we've had in the healthcare system has nothing to do infectious disease versus addiction. And it does reflect the stigma. And so when you sort of say to me, do I get jealous? Well, I get inspired. I get inspired by how we, as using science, and we can also, through our healthcare system, provide an infrastructure to help people. And to me, it's inspiring to do that. And I said, we can. Look at what we've done with COVID. We can come up with solutions to address the overdose crisis. Let's learn from lessons learned and use that narrative to get more resources. And so when you're telling me maybe I should write that paper, I said, absolutely, because it does identify the similarities in the patterns, right? The emergence of new infectious disease agents, the emergence of increasingly more toxic and addictive drugs, and it's going to continue. And it's not going to stop by itself. We have to be proactive. So
yeah, maybe you have a partner at NIDA who'd work with me on that. And I know where I want to be mindful of your time. Just to wrap things up, two questions quickly, but one is from Dr. Catherine Antley, who she's a dermatopathologist from Vermont and works on the International Academy on Science and Impact of Cannabis. She wants to know if you would support the value of warning labels on cannabis products like we have for tobacco or alcohol, or flashing lights when we have movies with warnings such as psychosis and mental health risks and the medical risks. And finally, to close out, what are your hopes for 2023?
Okay, so the answer is very simple. Yes, of course, I would support them. Look at all of the data on nicotine. They actually shown that it has a significant impact in behavior of people to purchase them. So yes, the data is out there. We don't need to reinvent them. And other countries are doing it, and it's actually basically reducing the amount of consumption of high doses of THC. What are my hopes? My hopes is that we do not forget the lessons learned from the COVID pandemic. And to me, one of the most powerful lessons, what were to me some of them, one of them was how damaging social isolation is and how much we need each other, and how important it is for our well-being to have those social, meaningful relationships. And in the case of substance use disorders, that are actually extraordinarily important. And so to be able to provide that social support and advance the science in terms of that helps us consolidate systems that provide it to people so that we can prevent substance use disorders, but help people achieve recovery. That's one. And the other thing that was made very clear to me from the COVID pandemic, that again is something that I feel very strongly crucial for substance use disorders, is that horrific health disparities that we are observing. And in the case of COVID-19, it became evident because there were people from low income or socially deprived or stigmatized groups were at much higher risk of getting infected and much higher risk of dying. And in the case of substance use disorders, we have seen how devastating the way that we as a society have dealt with by criminalizing, by penalizing, and using this criminalization as a means to, again, more negatively affecting vulnerable populations. And I hope that we don't forget those lessons from the COVID pandemic, and that we take those lessons and bring them into action plans to get rid of stigma, and to bring them into action plans to provide the support that is necessary for addressing prevention and treatment of substance use disorder. And we provide the resources and changes in attitudes that are necessary to get rid of structural racism.
And thank you. Thank you to my guests and experts who asked great questions today that inspired our conversation. And thank you, Dr. Volkow, for your time today, your service to our country. You continue to innovate and lead with a fresh look every year, and you are my rock star.
Thanks very much for having me, and keep on doing what you do.
All right, we'll be in touch. Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support of our sponsor. A sincere and warm thank you to Isaac, the International Academy on the Science and Impact of Cannabis, doctors educating on the harms of marijuana. Visit isaac1.org, that's IASIC1.org, to view their library that translates medical journals for public understanding, listen to their speaker series, and follow the science on marijuana. High Truth's producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Onit Lev. We hope we brought your day a little bit more High Truths.